This is a 68-year-old male patient. He had a history initially of fevers, night sweat, and weight loss. He had abnormal LDH and diffuse lymphadenopathy on both sides of the diaphragm, but no bone marrow involvement, not CNS involvement. This was on the biopsy, typical diffuse large B-cell lymphoma, which was CD10 negative but BCL6 positive, and who was classified as non-GCB, but with the overexpression of MYC and BCL2 protein, but without any translocation. So the patient received rituximab CHOP, relapsed 1.4 years later, received DHAP and ASCT, but unfortunately relapsed again and just had received CAR T therapy. So patients that had went already through 3 lines of therapy, and I think I'm really looking forward to see how Kieron Dunleavy will address the question of this patient. So Kieron, it's your turn.
Thanks, Gilles, for inviting me, and thanks to the Lymphoma Hub for inviting me to this symposium. So I'm going to discuss how I approach patients with relapsed refractory diffuse large B-cell lymphoma, talk about some novel, recently approved treatments that are available, and how I think about sequencing therapies in this scenario. Gilles has already presented the case. I won't go into it in detail again, but this is a 68-year-old male with relapsed refractory diffuse large B-cell lymphoma. He had the non-GCB subtype by the Hans algorithm and stage 3B, and would be called a double expressor lymphoma. And as Gilles has already said, you can see his treatment course here. He had R-CHOP initially, had 6 cycles of that. Then 1.5 years later, he had progressive disease, got DHAP and a autologous stem cell transplant, relapsed again a year later, and then got anti-CD19 CAR T cells. And then a year after that, he has relapsed again. So in terms of thinking about what the next steps are in this patient, I think that you can think about his treatment in a few different ways in terms of the US perspective. For patients with relapsed refractory diffuse large B-cell lymphoma, over the last few months, there have been a number of approaches and agents that have been FDA approved, such as tafasitamab and lenalidomide, Cytomxr, polatuzumab with BR. There are a lot of clinical trial options that have been presented and report very promising results. And then, of course, there are standard options for this patient as well. There are further immunochemotherapy platforms that he could receive, some single agents that I'll talk about a little bit, and then other transplant options and other CAR T cell options. So there's really a plethora of agents that are available for patients with relapsed refractory diffuse large B-cell lymphoma. I think that this illustrates some of them. There's a lot of interest in targeting CD19. This patient had anti-CD19 CAR T cells. Tafasitamab is a monoclonal antibody against CD19, and it has been combined with lenalidomide, and I'll talk a little bit about that. Loncastuximab is an antibody drug conjugate against CD19. There's a lot of interest in bispecific antibodies, or BiTEs, that in diffuse large B-cell lymphoma target CD20 and CD3. And I'll talk about some early results with these. And then there are a lot of other interesting targets for diffuse large B-cell lymphoma, CD79B, which is targeted by polatuzumab vedotin. There's a lot of interest in targeting CD47, and other targets like CD22 are very interesting in diffuse large B-cell lymphoma. So this is the LMINE study that combined tafasitamab and lenalidomide in patients with relapsed refractory diffuse large B-cell lymphoma. In order to go in this study, patients had to have 1 to 3 prior regimens. They were not transplant candidates, and they could not be refractory to their previous treatment. Shown here is the schema of treatment that they received, and the endpoint of the study was overall response rate with secondary endpoints, PFS, duration of response, and overall survival. So 80 patients with relapsed refractory large cell were treated. The overall response rate was 60%, and the CR rate was 42.5%. And in terms of long-term outcomes, and this data was recently published by Gilles, the progression-free survival, as you can see here, after 24 months follow-up, was very promising. The median progression-free survival was 16.2 months, and the median overall survival was 31.6 months. Loncastuximab tesirine is an antibody-drug conjugate against CD19, and this is a study of the agent in patients with relapsed refractory diffuse large B-cell lymphoma who had received at least 2 lines of prior systemic therapy. Again, the objective of this study was to look at efficacy, overall response rate, and safety of this agent. Shown here is the schema. And the characteristic, there were 145 patients who were treated with this agent, and the majority of them had diffuse large B-cell lymphoma. Some had this entity high-grade B-cell lymphoma with MYC and BCL2 or BCL6 rearrangements, and also primary mediastinal B-cell lymphoma. And shown here are the results with loncastuximab. The overall response rate for all patients was 48.3%. For patients with diffuse large B-cell lymphoma NOS, it was 50.4%, with 23.6% of patients achieving a CR. And for this entity high-grade B-cell lymphoma, all patients who responded achieved a CR. And the response rate in primary mediastinal lymphoma, the numbers weren't huge here, was less at 14.3%. And you can see again that the duration of response with this approach is very promising. The median duration of response was 10.25 months. Cytomxr then is another FDA-approved agent for relapsed refractory diffuse large B-cell lymphoma. It works in a completely different way. It inhibits XPO1-mediated nuclear transport, and the SADL study, which was recently published, looked at the activity of Cytomxr in patients with relapsed refractory diffuse large B-cell lymphoma. And while the response rate with the agent was modest at 29%, and the complete response rate was 12%, the median duration of response was 9.3 months in those patients who had a response to therapy. Polatuzumab vedotin is an antibody-drug conjugate against CD79B. And this is a randomized phase 2 study that was published earlier this year that compared Pola with BR versus BR in patients with relapsed refractory diffuse large B-cell lymphoma. As you can see from the progression-free and overall survival curves here, patients who received the Pola arm had a significant benefit. They had a higher CR rate of 40% versus 18%, and higher PFS of 9.5 months versus 3.7 months, and OS of 12.4 months versus 4.7 months. And based on this data, there's an ongoing phase 3 study called the POLARIX study, which is looking at incorporating polatuzumab into frontline therapy versus R-CHOP in patients with newly diagnosed diffuse large B-cell lymphoma. A lot of work has been done with the bispecific antibodies in relapsed refractory diffuse large B-cell lymphoma. And at the moment, most of these target CD20 on B cells and CD3 on T cells. There are a number of bispecific antibodies that are in development, including some of the agents that I have shown here, and there are others in development as well. I think that one of the agents that has the most matured data is mosunetuzumab. So this is a bispecific antibody against CD20 and CD3, and this was studied in 270 patients with relapsed refractory B-cell lymphoma, and 180 of these had aggressive non-Hodgkin lymphoma. Most of these had diffuse large B-cell lymphoma, but there were also some transformed follicular lymphoma patients and mantle cell lymphoma patients in this group. In terms of the patient that we're talking about, I think it's interesting with this agent that in this study, there were included patients who had had prior anti-CD19 CAR T-cell therapy, about 11.1% of patients on the study. And These are our early results with this bispecific antibody in aggressive non-Hodgkin lymphoma. Shown here are the different dose levels that were used. But you can see that the overall response rate is 37.1%, and the CR rate is 19.4%. And coming back to our patient, in that subgroup, it was a small number of patients who had had previous anti-CD19 CAR T cells. The response rate was 22%, and a few of those patients had a CR. So back to this patient's case, how do I think about next therapy? I think the first thing to consider is that he has had anti-CD19 CAR T cell and has relapsed on that. So the question is, how much is he going to benefit from another therapy that's directed against CD19? It might be helpful in this case to do a biopsy to see if he's CD19 positive or negative. And I think at this point, we still do not have a lot of data on retreating people with an anti-CD19 approach if they've already had relapsed refractory disease following anti-CD19 CAR T cells. So that's an interesting question. In terms of looking at the results of a lot of these early studies, it's important as well to note that some of the studies included patients who had one line of previous treatment, whereas other studies have included patients who have had 2 or more lines of previous treatment. And that's important in terms of looking at the outcome, because of course, those studies that have included lesser lines of treatment, may have better outcomes for that reason. And then, I think there are other approaches that can be used that are non-clinical trial approaches. The patient has a non-GCB subtype, so you could use single agents that have selective activity in non-GCB, such as BTK inhibitors or lenalidomide. But really, these agents as single agents are effective in inducing responses, but the duration of response has been very short in studies. So I think a lot of these options are very reasonable for this patient, and we can discuss them. And I think that a clinical trial of bispecific antibodies is a very reasonable approach for him, considering that he has already had anti-CD19 therapy and has had relapsed refractory disease on that. Thank you.